So your objective exam must be functional. So you want to make sure that, for example, if somebody says that they have anterior knee pain, it's no point just assessing the patient sitting on the bed and you look at the quadriceps contraction, because no one gets injured sitting on the bed. So you need to look at the type of movements and the function that would be relevant to why that athlete is getting pain on the anterior knee. So you might look at the quads as a specific test, but you're actually going to watch how they move and how they load that knee. That is far more relevant. And so other things that you should be looking at to be functional is watch the patient move and undress. So when they arrive at your treatment rooms, I always walk behind them into my treatment area because I've got a long corridor, and I watch to see if they're limping or if they have a change in gait or if they're favoring one side. So I start to get an idea of any limitations they might have. Before I assess movements, I look at their posture and standing. So I look at where their weight distribution is. Is it forward or back in their stance? And I look at their loading through their feet. I also assess their level of hyper or hypomobility. And I always perform the Baton's test because that will give me an indication of that level of laxity at those ligaments. And that can maybe also help me with my diagnosis. Some studies have suggested that more than 65% of your patient population are hypermobile. So laxity can be more of a problem than stiffness. I also look at, can they separate lumbar spine? For example, if it's a lower quarter injury, can they separate lumbar from pelvic dissociation? Can they move the lumbar spine independent of the pelvis? And what are their functionally limited movements? What are the things that they can't do? So if they say, I can't lunge, look at their lunging. If they say, I can't take my jacket off, look at them taking their jacket off, so that you can try isolate why they're developing these symptoms of pain or stiffness or nerve damage, and see if you can relate that to their function. So let's give you some examples of postural overload. So I always do like my one-liners with my athletes. So one of them is, if it ain't right at rest, it ain't right in motion. So if you find that your sportsman has pain at rest with certain postures, then you know if they're going to move, they're also going to have dysfunction. And also you get what you train. So if someone like these sort of athletes or sports people here, if they persist in training with these type of biomechanics, you're going to get the injuries because of that overload. And if you overload asymmetrically, of course, you're going to get asymmetric injuries. And if you spend your life throwing or serving, you're going to get injuries to your shoulder. So you get what you train. And also we need to normalize posture and normalize load. Osteoarthritis, unless it's genetic, is an overload injury. So osteoarthritis is not abnormal. Loading is abnormal. So osteoarthritis is a normal response to an abnormal load. So we want to correct the loading of that patient. So if we have a look at some of these, this lady is very hypermobile and very flat in the foot with collapsing of her medial longitudinal arch. And this type of foot pronation affects the whole chain coming up all the way up into the hips and the spine. This chap has a severe scoliosis, and so that's changed his scapular position. So this scapula is protracted with pseudo-winging, and this scapula is in adduction and downward rotation. But the scapula is not the problem. The problem is that the thoracic cage is rotated. The scapula is simply resting on the thoracic cage. So treatment of this sportsman here is not to the scapula, but of course to the thoracic spine, or to try and normalize the scoliosis. This chap here has got a very posteriorly tilted pelvis. Why? Because his hamstrings are so tight. So his hamstrings are so restricted, he cannot sit in long sitting. And a restriction of the hamstring is forcing a give into the thoracolumbar region here. And it's no surprise for you to hear that he has Sherman's disease or pulling of the end plates on the vertebral bodies because of that overload. This lady on the right is actually a physio, and she is hypermobile. So every time she treats a patient with manual therapy, her elbows go into hyperextension, and of course she's causing a posterior impingement of the olecranon into the trochlea. And so she gets posterior elbow pain because of that compression. So the treatment, of course, cannot be directly at the elbow, as in relieving the pain. What we have to do is get her back control so that she no longer hyperextends her elbow and compresses the posterior space when she treats. This chap here was a top professional cricketer for his country, and you can see how he hyperextends at the knee. So this causes a tension on the posterior structures of the knee and a compression anteriorly, causing antero-inferior patellofemoral pain. So this chap, because of his patellofemoral pain, if you just treat his knee locally, as you can see, you're never going to improve him. You need to improve him so that his knee no longer locks into hyperextension when he runs. And just out of interest, this little tendon here that is hyperactive in this image is actually his biceps femoris tendon, which is trying to tighten to compensate because there's something going on in the lumbopelvic region. Here's a dysfunction up here. If we look at this spine or this skeleton here, you can see the scoliosis. So the scoliosis here is convex to the low iliac crest on the left side, so that she has a high iliac crest on the concavity with a compensatory scoliosis convex to the opposite side in the thoracic spine. So because of this and this iliac crest height disparity, this is effectively a leg length difference. So this patient could come in with quadratus lumborum type pain on the right because of the high iliac crest. This left femur is an adduction, creating potentially an adductor tendinopathy as one of the injuries. This patient also now has a depressed adducted scapula on the right and a protracted elevated scapula on the left. And so this is creating overactivity of the levator scap and the upper fibers of trapezius muscles. So this sports person could come to you with unilateral back pain, groin pain, right rotator cuff type pain, left rotator cuff type pain, cervical pain, or even headaches. And you can imagine just looking at this malalignment here, that if you were just to treat the site of the pain, you'll be missing the source of the problem. And one of the first things you might have to do is do various treatment techniques and rehabilitation to level up the iliac crests to offload all these structures. So something else in our objective assessment, of course, is that we want to use specific biomechanical dynamic loading tests, especially if the injury is persistent or recurrent. So if somebody falls and lands on their knee and they get a hematoma or a bursitis, like a suprapatellar bursitis, then you don't need to do a biomechanical loading test. But if they say, when I run, as soon as I run, like over 5 kilometers, I start to develop knee or hip or ankle or back pain, you need to look at that running strategy and you need to see them loading to try and tell why they keep getting these persistent or recurrent problems. And once you've found a positive test, you can often use that test to test and retest, and also to use that principle when you start designing your rehabilitation program. So once again, use these tests to identify the source of the problem. So this, what you're about to see here, would be an example of a dynamic valgus. So this lady wanted to run a 50-kilometer race, 56-kilometer race in Cape Town. And you'll see now she's very hypermobile. So she presented with groin pain and SI joint type pain. But if you just treated the area, you'll completely miss the boat. Have a look at what happens when she does a step down. So her lumbar pelvic control is very poor. And look how that knee collapses into valgus or medially, foot goes into pronation. And you can imagine that if she's running downhill, that would replicate that kind of motion. And if she's running downhill, that's going to overload her hip, her back, her SI joint, her groin, her knee, and her foot. So it's very hard to actually tell which one is going to get injured. And that will depend on the type of activity that your sportsman is doing. So these type of athletes could come to you with hip impingement, patellofemoral pain, an AC, anterior cruciate ligament tear, recurrent lateral ligament sprains of the ankle, labral tears of the hip, unilateral facet type pain in the back, as I said, SI joint pain. So the number of injuries, ITB pain will also be common in this type of dynamic valgus. And once you've looked at the functional limitations, and once you've looked at the biomechanics, and you've looked at the person moving, then you might start doing special tests that are specific for that site of pain in that athlete. So you might do your strength tests, isometrics, isotonics, and so on. You might do length tests depending on what's specific. So you might look at Thomas's test, or look at piriformis length tests, or you might be looking, if it's a shoulder, you might be looking at the length of latissimus dorsi and the pectoralis major. You might look at load control tests. When they load, do they have motor control? So tests such as the active straight leg raise test or the march test, both of which have been validated. You might do various impingement tests if you think the problem is at the hip joint itself. And hopefully you know all of those, like the fader, the Faber, the fader, and so on. And that would be obviously a specific related hip course where we look at actual assessing the hip in isolation, whereas today's talk is again generic, looking at all sorts of problems and looking at assessment and rehabilitation in general. We always assess joint range of motion, and we look at things like the GERD, the glenohumeral internal rotation deficit, versus the TAM, the total arc of motion, which I use at the hip and at the shoulder, and the TAM, the total arc of motion deficit, which I look for differences in total rotation between the both sides. And we do specific assessments at the talocrural joint or the knee or wherever the problem is. I look at dynamic loading tests such as lunging, step downs, hopping, running. And on top of all of this, I'm always looking for mood disturbances, catastrophization, denial, fear avoidance, anxiety, depression, and all the things we've discussed. So just these images on the side, anything that loads, you always want to make sure that the patella or the knee, the middle of the knee, is in line with the center of the foot. That would be an optimal sagittal plane type motion. So people that run with the knee landing within the middle of the foot are less likely to get injured than in people where the knee will drift medially. So once you've done your assessment, both interview and your objective tests, which are specific and functional, as well as looking at posture and looking globally, then you have to clinically reason your findings and develop a working hypothesis. So don't just, again, launch into treatment. The more specific you are here, the better your outcomes will be, and the more trust the sportsman will develop for you, and the more job satisfaction you're going to have because your patients are getting better. So you want to make a provisional diagnosis. And I always say provisional because if there's a lot of inflammation, for example, your diagnosis might change depending on what you find. You want to develop short and long-term goals and start to plan your rehabilitation and your management. So really think. So as in particular physiotherapists, we need to be clinicians and not technicians. So putting a machine on somebody is simply being a technician, but looking for the source of the problem and developing treatment strategies. Now we're being clinicians and we can start to manage people better. So that's what that means. There's no one size fits all approach. There's no recipe. There's no protocol. Every sportsman or patient in front of you as an individual, and you need to be prescriptive in your management to get the best outcomes. So you need to prescribe, if they are competitive, a season-specific rehabilitation program. So pre-season, it's much easier because they're not being competitive. And post-season, you can do a lot of rehab because they're all Euros and you've got time to get the rehabilitation sorted. But if it's in competition, it's a nightmare because you might want the sportsman to rest, but the coach or the manager or the trainer might say that they can't rest, there's simply no time. And they're in competition, and every Saturday, for example, they have a match. Sometimes then you just have to do damage control, which means you just keep them going from one match to another. And that would be typical of a physio or doctor that is traveling with the team. So I've often traveled with teams at a national and international level. And sometimes you just have to try and keep them going till you wait till the end of the season when you can be more specific. But in season, quite a lot of research has gone into doing isometric work. So if they've got, for example, a glute medius tendinopathy, often doing isometrics in season will keep them going. Isometrics can be very helpful for analgesia that can help restore the pain and reduce the pain and help give them some control around that area. And so instead of doing dynamic loading, you might be more tendance just to do some isometric work for them in season. So I call that damage control. So you need to prescribe a rehabilitation program that is clinically relevant. So we need to do pain management, ice and protection. Then we look at flexibility and joint range. Then we use motor control, strength and endurance, coordination and proprioception, and functional rehabilitation. So ideally, if possible, we want to get that sportsman back to pre-injury condition. And obviously, sometimes that's not possible, but that's going to be potentially our goal.